Hello, can you, sorry, the slider of the audio was just low. You should have told me beforehand. So anyway, we can continue from there also again. Is the audio sound is the sound okay now? Anybody in the audience, is the sound audible? I think the slider was on the minus side, so that's why you couldn't hear, and I was unaware of it. Our internet is pathetic because this is supposed to be a 50 Mbps speed, and there's so much. Yes sir, till now it's okay. Okay, now it is audible. So I'll just start the bundle branch blocks, so nobody has missed any part of this lecture. So I'll start with the lecture again. So this is the bundle of phase, the right bundle branch, left bundle branch. We block left bundle branch out here. Okay, so now the current is going from right bundle branch towards the left bundle branch area, towards the left ventricle, lateral walls and all. Okay, so the vector is deviated towards 0 degree. Okay, so because the right bundle branch is out here and it is sending the current like this to stimulate the left ventricle, because contraction has to occur, otherwise the person will die. So lead 1 is becoming positive. It is happy that current is coming towards lead 1. So lead 1 is positive, positive, positive. And I had told you, like if 1 becomes positive, AVF has to become negative, because current will travel either like this or like this. It cannot travel like this. Okay, so this much you have to remember. So now lead 1 has become positive, AVF has become negative, 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 negative at minus 90 degree. So now we are in this quadrant. Okay, so this is which quadrant? Left axis deviation quadrant. So this is the left axis deviation quadrant. And now you must remember this, when left bundle branch is blocked, the current is traveling from right ventricle to left ventricle. Okay, so it's a big distance, lot of bulky muscles have to be crossed, and then the QRS widens. QRS becomes more than 3 small squares. Okay, at your level QRS is more than 3 small squares, less than 3 small squares, that's it. Okay, and so it is from one chamber to the other chamber, so QRS is more than 3 small squares. Now current is coming towards lead 1, AVL, V5, V6, and it is going away from AVF. Okay, so and it is going away from V1, V2. V1, V2 are here. Okay, now you tell me what will happen in V5, V6. You will see a very taller R wave, broad R wave, and there will be depolarization defect. There will be ST depression with concavity upwards, and a T wave inversion, and a left axis deviation. Okay, and reciprocal deep S wave in lead V1 and V2. So that is called complete left bundle branch block. And some people say you will see a M pattern in the R wave tip, so that is notching actually. There will be M pattern, so that is complete LBB. So the criteria for left bundle branch block is left X, L for left, L for left. Okay, left bundle branch, L for left bundle branch, L for left axis deviation. Left axis deviation, broad QRS, tall R in V5, V6, concavity upwards ST depression, inversion of T wave with reciprocal S wave, deep S wave in V1, V2. So I told you V1, V2, they lie in opposition to V5, V6. If something tall happens in V1, V5, V6, deep S will be drawn in V1, V2. Okay, now we come to right bundle branch block. So we have blocked the right bundle branch out here, and what will happen? So right bundle branch is blocked. So now the current is coming from left bundle branch to stimulate the right ventricle, because right ventricle also has to pump. Okay, so what will happen? The right bundle branch is blocked, so current is coming like this, lead 1 towards lead AVF, it is coming. Okay, like this. AVF is very happy, current is coming, so it is positive, positive, positive. AVF, lead 1 is not very happy, current is going away from lead 1, because left bundle branch is sending the current like this to like this. Okay, away from lead 1. So lead 1 is negative, and you draw at 180 degrees. So axis has come in the RAD quadrant, right axis deviation quadrant. So plus 90 to 180 degree. Okay, so now again it is from one chamber to the other chamber. So now you can think and tell what will happen to the QRS duration? QRS duration will widen more than 3 small squares, more than 0.12 seconds. Okay, and there will be ST depression and T wave inversion, and ST depression with concavity upwards, and you will see a RS-R dash pattern. Now this is a very interesting phenomena. You will see RS-R dash pattern in V1, V2. Okay, and there will be right axis deviation. So right R for right bundle branch block, R for right axis deviation, R for RS-R dash pattern. So you can remember like this. So RS-R dash pattern is also called as rabbit's ear. So you will see, like if you see a rabbit from the side, you will see one ear will look little short and one ear will look little tall. So rabbit's ear. Now we'll come to the how these rabbit's ear are drawn. So what happens when right bundle branch block happens? Now see, there is a, I will show you the ECGs later on, but I will just describe the pathophysiology why RS-R dash pattern is drawn in right bundle branch block. Now you see, this is the interventricular septum, right bundle branch is blocked. So interventricular septum has to get depolarized by the LBB, left bundle branch, or LAHB. So from whichever of these three leads, these fibers, the lead, they are innervating the interventricular septum, and it is from left to right interventricular septum depolarization. Okay, so R wave is out here, so it is perceived as small r. Okay, interventricular septum getting depolarized, small r. Then I said there will be S wave. Okay, so now the current is going after the interventricular septum is depolarized, the left ventricular free wall is getting depolarized. So it's making a R wave in wave V5, V6. Okay, because it is lying over the left ventricle, and reciprocal same S wave will be drawn in V1, V2. Okay, then the current has to depolarize the right ventricle also. Okay, again the current is coming like this. So then again V1 perceives current is coming like this from the left bundle branch. So that is R dash. Okay, so there is R, S, R dash, and always remember interventricular septum gets depolarized first in the ventricles. So this was about RBB and LBB. Now we come to little finer block, left anterior hemi block, and you must remember, like in around 99.9% of the times when you see a left axis deviation, it is because of LAHB, left anterior hemi block. And whenever there is a left axis deviation, you should look for deep S wave in lead 2 and lead 3, and that is, and with the left axis deviation, lead 2 and lead 3 having deep S wave, that is the criteria for left anterior LAHB, left anterior hemi block. So how that is happening? So LAH, so this is left anterior fascicle, we have blocked it. Now this part of the myocardium needs to be depolarized, but this fascicle is blocked. Now it will not be depolarized by the right bundle branch because there is no need, there is a left posterior fascicle out here. So it will send the current like this to the area where left anterior fascicle had to depolarize. So now what is happening to the vector? For AVF, current is again going away from AVF, and for lead 1 it is going towards lead 1, towards lead AVL, okay, away from lead 3. So lead 3 is very unhappy, lead 2 is also unhappy, and because current is going like this. So because LPF lies inferomedially, so current is going like this. Okay, so it's going away from lead 2, away from AVF, away from lead 3, and it's going towards lead 1 AVL. So lead 1 is positive, 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 AVF is negative, 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 place it at minus 90 degrees. So again left axis deviation. Now you will think there is LBB also causes LAD. There are many things that can cause LAD, but in LAHB, because it is within the same chamber, so the QRS doesn't widen. Okay, so there will be a deep S in lead 2, lead 3, and left axis deviation. So that is the criteria for LAHB. Then LPFB block. So this block is usually a diagnosis by exclusion. Okay, so when you cannot find any other cause of right axis deviation. Now let us say this is blocked, left posterior fascicle is blocked, so left anterior fascicle will stimulate the ventricles like this. So lead AVF becoming positive, and lead 1 becoming negative, right axis deviation quadrant. So when you have to comment on LPFB, left posterior fascicular block, it is a tricky diagnosis, and then you have to rule out various causes of right axis deviation, pulmonary embolism, right ventricular hypertrophy, RVH with strain pattern, or something like that. Okay, anything that is causing enlargement of right ventricle, blockade to the pulmonary artery blood flow, so they will cause strain on the right heart. So all these causes have to be, and in COPD, so all these causes have to be ruled out, and it is a diagnosis by exclusion. So when these things are not present, then you can entertain a diagnosis of LPFB, in which there will be purely a right axis deviation and nothing else to suggest a right ventricular hypertrophy or pulmonary embolism, in which you will see S1Q3T3 pattern. So ECG will be totally normal, but there will be a right axis deviation, and QRS will be of normal duration. So this is about the blocks, and now this is also important. This slide should actually have come before these 2-3 slides which I discussed just now. Now this is very important, and many of the times we ignore this. Okay, so this is intrinsicoid deflection. So there is something called as intrinsicoid deflection, which all of you should know to become very good interpreters of ECG. So intrinsicoid deflection is from the beginning of the Q wave till the tip of the R wave. That angle, that deflection, that is called intrinsicoid deflection, from where the R wave starts converting into a S wave, the distal limb of the R wave starts. Okay, so that is intrinsicoid deflection, and intrinsicoid deflection should not be more than 0.05 milliseconds. Okay, basically slightly more than 1 small square, it should not be more than that. That is intrinsicoid deflection. If it is more than that, so you can call it increased VAT. VAT means ventricular activation time. So when there is increased ventricular activation time, increased VAT, intrinsicoid deflection is more deep like this. So in other words, what is intrinsicoid deflection? You will see a nice R wave. Okay, in intrinsicoid deflection, when it is getting increased, so you will see a R wave, ascending limb of R, descending limb of R. Okay, so it will be like that. So this intrinsicoid deflection, it precedes the formation of left bundle branch, right bundle branch, LAHB blocks. So basically it shows that how the current from the endocardium, it is traveling to the epicardium. Okay, so this is what it is. So this is the intrinsicoid deflection. It is starting from here to here. This is normal and this is abnormal. Okay, okay. So these blocks we have done, and I'll come in full screen. This is again, see, intrinsicoid deflection is like this. So sometimes you will see in ECG these type of complexes, but there is no RBB or LBB or LHB, and after a few days or months the patient will develop a full-fledged left bundle branch block, right bundle branch block, or something like that. So that is the importance of intrinsicoid deflection. It precedes the formation of other blocks, and it usually signifies an organic disease. Again, out here you can see intrinsicoid deflection. So LBB we have done, tall R in V5, V6, M pattern, deep S in V1. Okay, so now the interesting part has started. So these are the ECGs. So we'll see. So some more people have joined. So okay, welcome everybody, Reena, Sankavi, Dr. Rashida, Nikhil, everybody, thank you for joining. And now see in left bundle branch block. So left bundle branch block from one chamber to the other, broad QRS, L for left bundle branch, L for LAD, L for left axis deviation. So you can remember and make a mnemonic like that. So now you see lead 1 is broad, QRS is broad, there is in fact no S wave. Okay, there is a R wave, broad wave, more than 3 small squares, and just by looking into lead 1, remember that circle, and you know the current is going towards lead 1. So AVF 3, they have to be negative. Okay, so we know there is a left axis deviation happening. That why? Because the current is going towards lead 1. if it is going towards lead 1, you see in AVL also, this is also broad only, broad and tall. Okay, there is no negativity out here. And the opposite of that you see, now also see in V5, V6, very tall R, broad. Okay, V5, V6, ST depression, concavity upwards, and a T wave inversion. Okay, so now there is tall R in V5, V6, deep S in V1, V2. So this is left bundle branch block. Okay, and you should also remember left sided blocks, they are most of the times they are organic. 99.999% of the times they are organic. You will see RBB also, and that is also organic, and but many a times you will see this in people who are asymptomatic, who have bad old COPD, bad old destroyed lung or interstitial fibrosis or something like that. They will have right bundle branch block, but they are asymptomatic. A left bundle branch block or a left anterior hemi block, if they start, you should actively pursue that patient's health status, okay, cardiac status. So you should do a TMT. Before doing the TMT, you should do an echo, rule out if the patient has dilated cardiomyopathy or HOCM or something. In that case, it is not wise to do an echo and make the patient run on that, and the patient can collapse and can have MI or can die also. So this is left bundle branch block. Again, this is another example of LBB. So you see a broad QRS in lead 1, tall R, keeping in mind the total size of the complex. Okay, so R is tall, and V5, V5, V6, ST depression, T inversion. Okay, deep S in V1, V2. Now something interesting you are seeing out here. P wave is tall. Okay, and but more than tall, it is broad. It is almost as the size of R wave in width. Okay, so just make a mental note of that. Then after looking at P wave in V1, you should look at P wave in after looking at P wave in lead 2, you look in V1 where the right atrium and the left atrial components are divided. Right atrium is upright P, left atrium is negative P. Okay, so you will see a isoelectric P wave. Okay, so out here in V1, the positive component is not seen, there is a negative component only. So there is a left atrial dilatation. So this is the take home message. Here also in V1 you see there is a negative P in V1. So this is left atrial dilatation. Now what else you have, you are seeing in this? You look at the R wave progression in V1 to V6. There is a Q wave, maybe there is a R wave. This is also small or almost as good as a Q wave, and here also there is a very small R. Okay, this can be because of the LBB effect, or this patient could be having a old anteroseptal ischemia or MI. So these two things you have to keep in mind. So this loss of R wave progression can be because of LBB per se, or it can be because of anterior wall disease, and the patient now developed LBB also. So LBB is a very tricky situation, and whenever the patient has LBB, you have to it is difficult to diagnose MI also, and we'll come to S. Garbosa's criteria. So this is another LBB. So you see this is tall R in lead 1, V5, V6. You see there's R wave, broad QRS, and deep S wave, V1, V2, ST depression out here, and T wave inversion. Okay. So now we come to right bundle branch block. So broad QRS, more than 3 small squares in V1, V2. RBB you have to look just in V1, V2, not in V5, V6 or lead 1 or lead 2, just in V1, V2. They are over the right ventricle, okay, interventricular septum. So RS pattern you are seeing out here, and there's a tall R, okay, and so there is a broad QRS, ST depression with T wave inversion, concavity of ST depression, and a right axis deviation. Now how right axis deviation? You see R and S, okay. So this is isoelectric complex in lead 1 and very tall R wave in AVF. So this is the impulses are coming towards AVF, that is why it is very tall. So there is a right axis deviation. This is another example of right bundle branch block. RS pattern, ST depression with concavity upwards, broad QRS, T wave inversion, right axis deviation. R is tall in lead 1 and AVF is positive. Okay, so there is a right axis deviation. Now this is again LAHB. Lead 1 is positive and AVF is negative. QRS is slightly broad, and look at V5 V6. Where is V5 V6? So there is no, they haven't shown V5 V6, but you can make a guess, like there is a tall R in V1, okay, and AVF is negative. There is a broad QRS, and this patient might be having a LAHB. So one sec. Yeah, LAHB. So QRS is not broad. Okay, sorry. So yeah, if you measure, QRS is almost as broad as 3 small squares, but is less than that. Sometimes you will get confused. Is it broad or is it normal? This ECG is falling in that category. Okay, so there is a deep S in 2 and 3. So LAD, deep S 2, 3, and a normal QRS, normal duration QRS. So that is it. Again LAHB. So there is a left axis deviation. So tall R, lead 1, AVF, S wave deep from 0 to minus 90. So there is a left axis deviation, deep S in lead 2, lead 3, deep S, and LAD. So that's the criteria for left axis LAHB, left anterior hemiblock. Now I told you LBB and LAHB, like they are usually organic blocks. Patient has a CAD in that case. Now you look at the R waves, small r, no progression, V3 no R, V4 no R, hardly any R. Okay, so old anterior septal MI. So LPFB we discussed, it is a diagnosis by exclusion. So you have to rule out RVH, right bundle branch block, pulmonary embolism, a pacemaker inserted in the apex, LV apex. Okay, that will again cause right axis deviation. If the pacemaker lead is in the right atrium or in the right ventricle, it will spread the current like that towards lead 1. So that will cause left axis deviation. If it is the tip of the apex, it will cause a right axis deviation. And anterior wall MIs, they can cause RAD, inferior wall MIs, LAD. So most of the MIs we have sort of discussed only. We will cut short the lecture today. And now we come to ischemia. Many a times patients will not have MI, but they will have ischemia. So you should know how to diagnose ischemia also. Now there are 3 types. Okay, there is a upsloping ST depression, there is horizontal ST depression, and downsloping ST depression in ischemia. And it's mild, moderate, and severe. Like upsloping is mild and downsloping ST depression is severe, which means the recovery is poor. Okay. You can have ST dependent changes, rate dependent changes in ST segment, but that is different. So this is upsloping, horizontal ST depression, downsloping ST depression. Okay. So if it is just upsloping ST depression, so it is just ischemia. And sometimes you will see upsloping ST segment depression with a tall positive T wave. So that could mean patient is having anterior wall MI. So this is a take home message. In the ST depression also there could be an MI. Okay, if there is a tall T wave with ST depression, anterior wall MI. Now you see this ST depression, this is a rate dependent ST change. So you see the heart rate is 59, out here 85, and there is slight ST depression, out here it is normal. Okay, so these are subtle changes. These are subtle changes in ECGs complexes, and you, like I always say, you have to be like a detective. You have to be very suspicious. Why is this an elevation or is normal? Is it J point elevation? And then you will detect. And many times you will make mistakes also, which is fine. Nobody is perfect. And this is horizontal ST depression. Now you might say, sir, this looks like a downsloping. I'll accept that also. Okay, so for me it looks like a horizontal or downsloping ST depression and sign of moderate ischemia. Out here you see there is T wave in, so this is a downsloping, severe downsloping ST depression in anterior leads. Okay, so for such a patient you should not do treadmill. The ECG is sort of diagnostic, and if you make these patients run on the machine, you might do more harm than good. So this is a downsloping ST depression. So this is again a downsloping ST depression. I kept this ECG. This is ECG from here only, where we are working and you people are studying. And in this there is a very special phenomena. You will see a R on T phenomena in lead V1. R on T phenomena is a very serious event in the electrical activity of the heart, and you have to be very careful. You have to pick it up, because this can start a very fatal ventricular tachycardia. Okay, that impulse is happening when the myocardium is totally vulnerable and suddenly a VT starts. So this is R on T. Okay, the T wave is ending and R has fired. Okay, this is R on T. Okay, this is R on T. Then you see in lead V3. So out here also you see there is a R on T. Okay, so this is R on T, and it is a very dangerous sign, and you have to be very careful. Maybe you should start the patient on beta blockers or some amiodarone, especially if the patient has had MI. In that case, the ventricle is irritable, the myocardium is irritable, and then suddenly this R on T will start, and it will start a fatal VT, can start. Now in this ECG, it looks like a totally normal ECG. There is no ST elevation, there is no coving. Okay, and many a times you should know that MI in anterior MIs, the progression of R wave is lost, and sometimes just the progression of the amplitude of R wave, it shortens, it narrows down, and that is the sign of MI. But if you look like this, okay, ECG looks normal. Now you see in this patient ECG, you look at the progression of R waves in V1 to V6. So V1, V2, V3, V4, V5. Okay, so there is no progression. So this is old anterior wall MI. Okay, now again, okay, so this is the blood supply of the heart, and it is very important. You can get a short note or even a long note on blood supply of the heart, and you should know about the blood supply. It is very important, and you can diagnose MIs based on the blood supply and vice versa. If you see some change in the ECG, you can tell LAD is blocked, RCA is blocked, or circumflex is blocked. Okay, so there are two arteries, left coronary, right coronary, left coronary, right coronary. Left coronary divides into LAD and circumflex. This is the circumflex, this is the LAD. So there are further diagonal branches which supply different areas in the interventricular septum and in the myocardium. Okay, so LAD, left A, LA, I am trying to make a mnemonic for you people. So A, LAD, left, L for left, A for A, anterior. Okay, so I have highlighted also so that you can make a mnemonic in your mind, a visual mnemonic. Anterior wall of LV, anterior lateral walls of left ventricles, anterior 2/3 of septum, interventricular septum. So LAD supplies these areas: anterior wall of the LV, anterior lateral wall, and anterior 2/3 of interventricular septum. So that is LAD. Then circumflex, left circumflex, posterior lateral, anterior lateral LAD, posterior lateral LCX of the left ventricle. Then we come to the right coronary artery. So it's R for right ventricle. Okay, and so it supplies the right ventricle, inferior surface of the heart, and true posterior surface of the LV, and posterior 1/3 of septum. Anterior 2/3 of the septum is LAD, posterior 1/3 is of the interventricular septum is supplied by RCA. So these things you have to know in detail. You can get a short note also, and I think we have discussed this slide before, and which leads to look for in which all MIs you will find. So right ventricle, you can see in V1, V2 slight changes. You can see also in V3, V4 R on the right side. Anteroseptal V1 to V3, some people take it at from V1 to V4. Septal is V3, V4. Some authorities say septal is V1, V2. So you have to mention both. Lateral wall V5, V6, lead 1 AVL. High lateral is just lead 1 and AVL. Okay, other leads, they will not show any MI changes, only lead 1 and AVL. So that is very high, lead 1 AVL. Okay, remember that circle again. Anterior wall V1 to V6, anterior wall V1 to V6, extensive anterior V1 to V6, lead 1 AVL. So this is for the anterior surfaces. Then for inferior wall, look in lead 2, lead 3 AVF, posterior wall mirror image of V1 and V2. Okay. Then right ventricular infarction you see in V1, V2, V3R, V4R. You have to by heart it. You can draw and again and again, and you can learn it. Okay. So that is. Then there is a lead AVR, and it is a very important lead, and most of the times we ignore it. We neglect this AVR. Somehow we just blindfold our eyes and see in lead 1, lead 2, lead 3, AVR, AVL, AVF, V1 to V6, and we don't give importance to AVR. But it is a very important lead if you know what to look for in AVR. Whenever there is ST elevation in AVR, it signifies a very serious organic disease, a widespread organic disease in the myocardium. Now see out here, AVR ST is elevated. Now see what's happening out here. There is coving, anterior wall MI, ST and T are merging together. Okay, you can't say there is where ST is ending. Okay, then you see in lead V5, V6 there is ischemia happening. Lead 2 ischemia, lead 3 ischemia. So it's a widespread change. Okay, so that is the importance of AVR. And in AVR the complexes will become, there will be ST elevation when there is a flexion of the inferior wall 2, 3 AVF when they are showing MI changes. There will be ST depression in AVR. Again, there is ischemia in lateral walls. Look at AVR, there is elevation. Elevation can be concavity upwards or convexity upwards. So both ways it is significant. So this is again you see the level of ischemia, lead V2, V3, V4, lot of ischemia is there. And how you determine where the ischemia is? Now the PR segment is the isoelectric line. So everything has to start and come at that point. Now out here S is starting, but it is not reaching here. So roughly if there are more than 2 square in duration and 2 square in depth, there is ST depression or ST elevation, it becomes significant. But you should be sharp enough to pick up a one small square change also. I will show you an ECG which we diagnosed out here. The patient is still here, we thrombolize the patient, and it's a very important, very interesting ECG. So these things we have done. So this is J point elevation. Okay, so elevation or depression of more than 2 small squares, they have mentioned as 3 different authorities will say different things. So more than 2 in duration and 2 in depth or height, they become significant amount of ischemia. And especially when these ischemic changes, they occur in association with exercise or exertion or a lot of emotional stress, they become very significant because they are the triggers for MI or some cardiac ischemia. So VAT we have discussed, and these we have discussed, these we have discussed. So this is what you will see in MI. Initially there will be hyperacute T waves and there will be coving, slowly they will settle down, T will invert, the Q will develop. So we have discussed this endless number of times, this finding, and the progression of R waves may diminish in anterior wall MI. So we'll just take a small break guys for 2 minutes, and then we'll start again. Okay guys, welcome back. And is my audio audible? Please type in the comments. Can we continue? There's a lot of buffering, and it's I think 2 or 3 minutes behind on the phone. So if you're not hearing, so we'll start from slide 143 again, and I'll rush through. Okay, so Nikhil says it's okay. Thank you, Nikhil. So now, so in that ECG where I said there is merging, okay. So in right ventricle, so ECG changes in anterior MI. So these we have discussed: merging of ST with T, hyperacute T wave changes, and reciprocal changes in opposite leads. If there is anterior wall MI, there will be ST depression in 2-3 AVF. Inferior wall MI, elevation in inferior leads, ST depression, reciprocal ST depression in lateral leads. And now how you will say this is, sir, this is a reciprocal change and this is not because of lateral wall ischemia. After few days, if the changes persist, maybe it is a sign of ischemia also. Patient has had inferior wall MI plus he also has lateral wall ischemia, because many times we have seen patients, they come with inferior wall MI, we thrombolize them, after 2 days they develop anterior wall, acute anterior wall MI. So this keeps on happening. Okay. Now right ventricular infarctions, many of the times you will be pro at diagnosing anterior inferior MIs, but right ventricular infarction we miss. Now first thing is, we have discussed in the previous lectures, whenever there is inferior wall MI, you have to think of right ventricular infarction, okay, and you have to think of posterior wall infarction. So you look actively for inferior wall MI, look for RVI and posterior MI. What you will see in right ventricular infarction, there will be ST elevation in lead 3 which is greater than in lead 2, and you will see ST depression in lead 1 and AVL. My dogs are knocking at the door, so I'm sorry for the disturbance if you are hearing their sound. And you will see ST elevation in lead AVF which is greater than ST depression in lead V2. You have to just by heart it, and that circle I will explain how these changes are happening. Then findings which are suggestive of right ventricular infarction, these are the findings, okay. So, and echo, TMT, ECG, they can all be normal. You should remember, ECG can be totally normal in MI, TMT can be normal in very bad CAD also. All the triple vessels might be blocked, TMT will be totally normal if the patient has good collaterals. Echo can be totally normal, only coronary angiogram is confirmatory, and it will tell you that the patient has a advanced or mild coronary artery disease and he needs intervention or not. And always do an echo before you do TMT. Now there is a state called stable chronic phase of MI. After the MI has occurred and few weeks have passed by, so the ST elevation you will not see anymore, and there will be Q waves, and there can be R waves. And if you have thrombolized the patient very early, patient came with chest pain, hyperacute changes, ST coving injury taking place, you thrombolize with tenecteplase or urokinase or streptokinase, and patient was lucky and his arteries opened up. So in that case, the R waves will come back, and in such cases you will see thrombolysis induced VPCs also. So you have to be careful of all these things, and you have to be observant, okay. And T may be flat or small or inverted in the chronic stable phase of MI. So this is ST elevation after 3 weeks, okay. So you see this patient had MI and ST is so elevated and 3 weeks have passed by. By this time the ST should have come down, but ST is so elevated. So in such cases you have to think of formation of left ventricular aneurysm, which is a very serious thing. Patient should be referred to a vascular surgeon, a good cardiothoracic surgeon, and maybe that patient might need some Teflon graft over the LV wherever it is about to rupture. Just like a cycle tube, it is weak, it inflates out, and after some time it bursts, okay. Nowadays we have tubeless tires, but the tubes, so you can think of that simulation. or ST elevation might mean there is an ongoing ischemia. There is something called as Prinzmetal's angina. So patient will have chest pain, ST elevation, you give sorbitrate, the ST elevation might settle down, the pain might settle down. But in MI pain and ECG changes because of MI, they will not settle down with sorbitrates, nitrates. Okay, so you have to keep this in mind. Then there is a condition called pseudo normalization of T in a patient who has had MI before, and if a patient has had MI before, I am getting disturbed by a beast. I know he is knocking at the door. So what is pseudo normalization of T? So T is inverted. Patient is coming to you in the OPD for years, is coming to you, and again he comes to you with mild chest pain. T is upright, and if you don't compare it with the previous ECGs where T was inverted, now the T is upright, that is a bad sign. The vector has changed, MI has occurred. Okay, that is why the T has become upright. So always compare the ECG with the previous ECGs of the patient. And okay, so this ECG we have seen. So this is marked ST elevation from V1, very tall ST elevation. Okay, and V2, V3, V4, V5, V6. In inferior leads also ST elevation. Lead 3, there is ST depression. Here there is elevation, and lead AVF also there is mild upstroking of the ST. So this patient has a very advanced extensive anterior wall MI. Lead 1, AVL, V1 to V6. So this is extensive anterior MI, but if you look at a glance, if you are very busy and you just look like this, you might just say, oh, this is anteroseptal MI. That is also serious, but patient has changes in so many leads: coving, flat T, coving, Valencine, high LAD block. Valencine, biphasic T is Valencine. It signifies a high LAD block. Okay, and V3 coving, V5 T inversion, flat T, lead 1 coving, T inversion, lead AVL coving, T inversion. You have to be this smart, you have to pick up this coving, and you will save so many lives. This is inferior wall MI, ST elevation coving in 2, 3 AVF. Okay, lead 2, lead 3, and AVF ST elevation is there. So okay, so RV infarction you will see in association with inferior wall MI. Okay, and lead V1, V2, they are also looking towards the right ventricle, but they give you only the partial view of the right ventricle. Most of the right ventricle is beyond the area of V1, V2. V1, V2 are looking at the interventricular septum. They are also looking at the right ventricle. Okay, you have to use imagination. I don't know how to explain. LV, RV, interventricular septum, V1, V2. Okay, now RV is out here, so little bit of area of RV, V1, V2 are showing. So you won't see whole of the changes of right ventricular infarction in V1, V2. For that you have to take V3R, V4R, V5R, and if there is ST elevation of more than 1 millimeter, one small square in V4R, it is a very significant change, and it shows poor prognosis also. So what is the criteria for RV infarction? Lead 2, 3 AVF, there is ST depression in lateral leads, ST elevation lead 3 more than in lead 2. Okay, so why there is ST elevation in lead 3? And just a sec guys. Okay guys, so criteria for right ventricular infarction we were discussing. There is ST elevation in lead 2, 3 AVF and reciprocal changes in lateral lead. So this will signify inferior wall MI, and because the right ventricle is lying like this, so patient's feet are here, body is there, so RV. Okay, so inferior wall MI and right ventricle. Then there is ST elevation in lead 3, which is more than in lead 2. Why? I will show you in that circle. And again for the same reason, because 3 is over the right ventricle, it is sort of looking towards the right ventricle in this case. Okay, lead 2 is on the left side, it is towards the left ventricle side, lead 3 is towards the right ventricle side. So just imagination. Then ST elevation in lead AVF is greater than ST depression in V2. Now again the circle will see. Okay, ST segment elevation in AVR more than 1 millimeter is diagnostic of RV infarction. Now see, this is the right ventricle, V1, V2 is just out here only. Now this area is infarcted, so there will be ST depression in V1. Okay, and lead 3 also the changes will be seen. Now this patient was on a treadmill, the doctor made him, patient came with chest pain, and doctor said we will do the TMT, and they did the TMT, and patient started having chest pain again. So what has happened? Patient has developed a right ventricular infarction. Okay, you see in lead 2, lead 3 and AVF, this is inferior wall MI. Then ECG changes of ST elevation in 3 more than in 2, inferior wall MI, right ventricular infarction. Okay, now we see, okay, now the same patient we took V3R, V4R and so on. Okay, so you see ST elevation, nice ST elevation you are seeing. So V3R, V4R, V5R, V6R, there is ST elevation. So this is right ventricular infarction in setting of inferior wall MI. So right ventricular infarction changes, they will be present just for few hours. So if you take the ECG again after some time, you might miss these changes. So V3R, V4 are very important in the initial changes, initial hours, and persistent ST elevation in right precordial lead, especially V4R, they correlate with high mortality and morbidity and poor ejection fraction. So the outcome is not good. And right ventricular infarction, it will limit the functioning of the right ventricle, it becomes less compliant, and there is poor LV filling because of it. So always be careful not to decrease the preload of the patient's heart in inferior wall MI. Avoid diuretics, beta blockers, and beta adrenergic drugs, morphine, especially nitrates. And because nitrates, people think MI, so you just give nitrates. No, it's not like that. Nitrates, if BP is low, avoid nitrates. Inferior wall MI, give IV fluids. Normal saline you can give, and then add vasopressors slowly, bring the BP up. You may add nitrates then. Okay, so and you do early PTCA, so active intervention. Treatment we have already discussed, IV fluids, inotropics, and early intervention, PTCA. So this we have already discussed. Inferior wall MI, LAD, bradyarrhythmias, lateral wall MI, anterior wall MI, it will cause RAD, tachyarrhythmias, tachycardia. So this is the patient's ECG, which we have this patient right now also, and it was admitted by another doctor, and I think the JR had admitted, and he said, sir, the patient has ischemic changes, has come with ischemia, so we have admitted as ischemia, so please see the patient. And we were on call, so we saw the patient. Okay, so this is the first ECG. I saw this ECG. I said this is inferior wall MI and with posterior wall MI, and we should thrombolize. And they were little wary, and they thought why I am saying this, there is no MI. But then I said you take the ECG every 15 to 30 minutes, and TROP-T was negative. I said do TROP-T again after half an hour. So this is the second ECG. Okay, so you see out here why I said there is inferior MI. Just this elevation, just a small tiny elevation, you have to be really suspicious, and you have to be like a detective, like Sherlock Holmes. This is the MI for me. Okay, there will be doctors who will say nahi, this is not MI, and next day they will say, oh ye to Q ban gaya. No, you should not do that. And so this is the MI, and you have to be sharp enough to pick up this change. And then you look in AVF. Okay, AVF, sorry, the AVF cord cut, maybe it will come in the next slide. So this was it. Yeah, lead 3 again, elevation. Okay, so again I thought this is MI. So now you look in lead V1. Will come to V1 in the next slide. So this is early, then after few minutes, after 1 hour or something. Okay, so the changes are slightly progressing. So lead 3, out here you see lead 3, the coving has worsened. Okay, then out here again the coving is there, severe coving, and out here this is downsloping T inversion also. Now see in lead 3 there is elevation, after few minutes coving increased, here there are artifacts. Okay, so now you see in V1, V2, this is interesting. Now in V1 R wave is tall, and if you just look at this ECG like this, you will say very good ECG, and there is no ST elevation, there are no Q waves, and progression of R wave is good. But no, you see in V1 and compare it with V2. Okay, V1 we are getting a very good R wave, that is posterior wall MI, tall R in V1 with mild ST depression and upright T. If you keep it in front of the mirror, that R becomes Q, ST depression will become elevation, and T in upright will become coving. T upright will become inverted. So that is posterior wall MI. So whenever you are suspicious of inferior wall MI, you look for posterior wall MI and right ventricular infarction. This patient is doing fine. We thrombolized this patient, and the trop T became positive. We thrombolized the patient when the patient's ECG was normal looking, and we suspected, we did the ECGs again, trop T was positive after 15 or 20 minutes, and we caught the patient on time and thrombolized it. So now she is stable and she is fine. And always be careful when you prognosticate the patient, because suddenly after 3 days, 4 days, they may have a ventricular infarction and interventricular septum infarction, and they may develop severe VSD or MR or something like that. So be guarded when you prognosticate. Now you see V1 tall R, V1 V2 tall R. Now after few hours, see the amplitude of V1, R wave in V1. This is small. Here it is so tall, so much tall that it's taller than V2 also. This is posterior wall MI. Okay, so you have to always look at the ECGs in a serial way, serial manner. Okay, label them as 1, 2, 3, 4, put the time, patient's name. Now something interesting is also happening out here. There is a slight subtle left axis deviation which is progressing. Now you look at the axis of QRS. So here the machine will detect P wave, QRS and T wave axis. So this is 35 degrees, this is 26, this is 22, this is 21. So subtle LAD is occurring because there is an inferior wall MI. Inferior wall MI, LAD, anterior wall MI, RAD. Okay, so this is the best ECG, and as the MI is progressing, the axis is changing. So this is a very good ECG, very good ECGs. So inferior wall MI, so we have seen enough of the ECGs. Okay, now just the last topic in MIs, so we'll finish it fast. And so it says that a beautiful girl and a smart boy. So the girl saw this guy, looked him in the eyes, and she had a fibrillation of the heart and she collapsed, and the boy revived the girl. Okay, so that is falling in love. But every time heart fibrillating is not love. Okay, it can be serious consequence of some serious heart disease. So we will talk about atrial fibrillation. And this lady, she had chest pain, and sublingual nitrates did not alleviate the pain. Okay, and ECG showed atrial fibrillation, inferior wall changes in, and atrial fibrillation, and she was admitted, and it did not subside, and she was giving cardioversion, and she had the rhythm became normal, and now this is the ECG. Okay, so now you look at, actually this patient is having atrial MI. Okay, so this is the most finest of the topics, and atrial MI we will never even think of if we are not looking for it. So whenever the patient comes with atrial fibrillation, think of atrial MI. Let the fibrillation settle down and atrial MI might be there. Sometimes you will get a ECG. Patient comes, you do the ECG, trop T is positive, ECG is normal. So think of atrial MI. This is another take home message. Okay, trop T positive and ECG is normal looking, apparently a normal looking. You look at the ECG again. Don't make it a ego hassle that oh no, it's normal. You look at the P waves. Look for posterior wall MI like in the previous ECG. So in AVR there is ST elevation of the distal limb of the P wave. Okay, this is also called PT segment. In inferior leads there is depression of descending limb of the P wave, PT segment. Okay, so out here, so you see this depression. This is not a Q, this is depression. Okay, of the P wave. This is the isoelectric line. So the P is extending beyond, depressing more beyond the isoelectric line. This is atrial MI. Okay, this is atrial MI. Distal limb is going down, is sagging in inferior leads. So you have to pick up these leads, these changes. Okay, in V1 what is happening? It is there is a ST elevation of the distal limb of the P wave, PT segment. Okay, so that is the change. This is the change. You have to pick up this change. Okay, this is atrial MI. So what you will see in atrial MI, there will be ST segment elevation in 2-3 AVF because of inferior wall MI, PR segment elevation in AVR and V1. Okay, where you were saying double arrows, PR segment. Okay, and there is a PR segment depression in 2-3 AVF out here, 2-3 AVF. Okay, and PR segment depression in 2-3 AVF and P wave axis deviation will be 67 degrees or more. So if you reject this diagnosis, you will miss the diagnosis. You have to diagnose it, and because trop T is negative, trop T is positive, ECG looks normal. Look at the ECG again, look at the P waves, look for posterior wall MI also. Then the minor criteria. Okay, so sometimes these criteria might not meet fully, and P wave is like this in V2 and biphasic in V1. So you look for M pattern, W pattern, irregular P wave, chest pain, trop T positive. So like that you have to conclude. Okay, this is from Brown-Waltz. So again atrial MI. So 2-3 AVF, you see PT segment is depressing beyond the isoelectric line. Okay, 2-3 and AVF. So you have to see a lot of ECGs, and then only your confidence will come and you will be able to say, okay sir, this is atrial MI, and that was atrial MI. Then posterior MI we have discussed. This is inferior posterior MI. Again subtle ST elevation. Okay, don't wait for the patient to develop 2 mm rise of ST elevation and then you will say, now this American Association, this says now this criteria is meeting, now I will say this is MI. That MI criteria we will meet, but you have to pick up the MI before that only. That will set you apart from the others. Okay, so that is how good you should be. And in 3C elevation, and there is a R wave, and put it in front of the mirror and it will become a Q wave. Okay, then this is a normal looking ECG, but this is an inferior posterior MI elevation. Okay, merging of STT elevation. Okay, and it's above the ST isoelectric line. So sometimes you will get dazed after looking 10 or 15 ECG. The 16th ECG column you will just look like that. That is where you will make mistakes. So I can actually see coving out here also. I can see coving out here also, and and tall R in V1, V2. Okay, so this is posterior wall MI. The again posterior wall MI, ST coving, and there is reciprocal change in the lateral leads, tall R in V1, V2. Okay, so we will miss the MI if we don't look for it. That is a take home message. You have to think of atrial MI also, especially if the patient comes with atrial fibrillation. Okay, you can get a short note on this, and this topic should be nicely, you look at this topic nicely, and atypical MIs, like you can get a question or a short note. Whatever I have taught you till now, it is important from the clinical point of view and from the theory point of view also. Then this is merging of ST and T. So you see out here, you can't say where ST is ending, where T is starting. This is the subtlest sign of MI starting. You have to pick up the patient here and thrombolize. Okay, anterior MI. So V1 coving, T inversion, V2, V3. So MI has sort of is still happening. See, now you will say this is Q wave, so no need to give thrombolysis. This is not a Q wave. This is a R wave. The slightest upstroke makes it R wave. Then this is the Q. Sorry, this is the S wave. First negative is Q, then there is a R, then is a second negative Q, S wave. So this is R S, R S, R S. Okay. So this is anterior MI, anteroseptal MI actually. So this is wrongly written. So, and after some time this is the same ECG. So patient developed ST elevation out here also. Okay. Now I can say this is anterior MI. Inferior MI, extensive anterior. So everywhere there is elevation. All the leads there is elevation. Extensive, inferior, extensive anterior, and inferior MI. So this is high lateral MI. So in AVL you see there is elevation and squeaky vocal. So you should repeat the ECG again and do trop T and do the echo also, which will help you in confirming the diagnosis. So this is something called as non-Q MI and NSTEMI. So you will see R waves are always there. There is coving, Valencine, biphasic T, high LED block, coving, R wave is there, T inversion. So you will see deep symmetrical T inversion, okay, non-Q MI. Now what all differentials you should keep? Be in the last few slides, so hang around and we'll finish this topic today. So WPW, pre-excitation syndrome with negative delta waves, they may mimic pathological Q waves. Okay. IHSS, idiopathic septal hypertrophy. Okay. So in that you will see, because interventricular septum is making small r in V1, small q in V5, V6. Now you just imagine there is a focal septal hypertrophy, it will make a good quality R wave in V1, showing as if there is RVH, and a good quality Q wave, which will be denoted by a capital Q. So then you might think the patient is having an MI. Okay. So that is another thing. So this is a take home message. Then LVH, left ventricular hypertrophy, it may cause QS pattern or poor progression of R waves from V1 to V3, because LV is so dominant. Otherwise also LV is so dominant in the ECG complexes from V1 to V6, and you imagine there is severe left ventricular hypertrophy. It will not let the right ventricular leads V1, V2, V3, it will not let them manifest. So this is a previous slide, we have already done this, and now you should always remember, if there is LBB, a patient has normal ECG, he is a follow-up patient, he comes with chest pain, ECG is just showing left bundle branch block, you should remember LBB will not cause chest pain. Okay, so it is either unstable angina with LBB or it is MI evolving with LBB. Do serial ECGs, admit the patient, monitor, and do trop T, echo, bedside echo, and think of MI, and you will get an MI in that patient, and chest pain will not be settling down with nitrates. And in the pre-existing LBB, this is the most hot topics for MDs, how you will diagnose acute MI in the setting of left bundle branch block, because the left bundle branch totally ruins the configuration of the contours of the complexes, especially the complexes over the lateral walls. Okay, V5, V6, lead 1 AVL. So how you will diagnose acute MI in LBB setting? So these are few points you should remember. You can come back and see these slides again and make notes, and if you make notes, you think you have mastered Leo Shamroth and Goldman and Marriott and ECG made easy, and so this is cool stuff. So you will see Q waves of any size in 2 or more leads in lead 1, AVL, V5 or V6. So why will Q waves will be there in the lateral leads, because the and this is one of the most reliable signs and probably indicates septal infarction. Okay, now there is a LBB, left bundle branch is blocked, and the right bundle branch is sending the impulses towards the left bundle branch area, depolarization area, and there is an infarction, septal infarction. So you will see Q waves because the septum is activated early from right ventricular side in LBB. So the normal looking Q wave vanishes, but because of the lateral wall MI, the Q waves appear. Normal Q wave is because of interventricular septum. Pathological Q wave in V5 V6 will occur in lateral wall MI. So there can be notching on the downstroke of S wave, on the upstroke of S wave, which are Q wave equivalent. Okay, and this is very important. And also, if remember that S usually is not seen in the lateral leads. Now the vector is changing. There was a left bundle branch block, there is a left axis deviation, broad QRS, T is inverted, ST is depressed, and MI has occurred. So you are seeing RS complex in V5 V6 rather than the normal R wave, broad R wave in V5 V6. So this S wave is equivalent of a Q wave. Okay, downslope of Q wave slurring, upstroke of Q wave slurring. Okay, and there is a RS pattern in the lateral leads in the patient who just had LBB with just a tall R in V5 V6. Now that ECG has S wave also. So that is Q wave equivalent. Or you see a RS pattern in lead 1 V5 V6. So this is also S wave equivalent. So this is very important. I will come to Garbosa's criteria, it will become more easy. Then there is something called as concordant T waves. So in a normal left bundle branch block, you will see tall R in V5 V6, deep S in V1 V2, ST depression, concavity of first, T wave inversion. Now this patient is coming to you, and maybe he was coming to you with chest pain, unstable angina for a few days, and you kept on giving sorbitrate or nicorandil or something else, flavidone or something like that. Now this patient's ECG, the T has become upright, that LBB T has become upright, the vector has changed, the MI has occurred. Okay, so that is called pseudo normalization, and we also call it concordant T wave. So LBB is there in this ECG, broad QRS, left axis deviation is there. Okay, and there is a acute MI occurring. I will show you another ECG which is more better. So this is Garbosa's criteria. So this is for diagnosing acute MI in the setting of LBB. So okay, so Ranjana says, good evening sir, server down. So I hope everybody is seeing my ECGs, and just Ranjana's server was down. Okay, anyway, I'll take the lecture again if you guys want it. And today the audience is less, and by the way, today we crossed 600 subscriber mark, and this is all because of you guys who have subscribed and liked the videos, and I'm really thankful to you. And please tell your friends also to subscribe, and this will help us, it encourages us. So you see the smile on my face. 600 members today, subscribers today. So this is the last topic, Garbosa's criteria. We call it Garbosa's S is silent. So there is elevation of more than 1 millimeter in leads with positive QRS complex. Okay, anterior leads, lateral leads, and this carries 5 points. Okay, now you see why just 1 millimeter ST elevation in leads with positive QRS. Now there is a LBB. Okay, there is ST depression in LBB, but then depression has gone into elevation. So even 1 millimeter of elevation means from ST depression of maybe 5 small squares to 1 positive. So it is 6 small squares ST elevation. Okay, thank you Nikhil, Ranjana, Sanjana, thank you everybody. So that is 1 point ST elevation in the lateral leads. Concordant ST depression of more than 1 millimeter in V1, V2, V3. So this carries 3 points. 5 points for ST elevation in lateral leads where there was ST depression. Okay, and concordant ST depression in more than 1 in V1, V2, V3, 3 points. Then ST elevation more than 5 millimeters in leads with a negative or discordant QRS complex, 2 points. Now again this is like just first point. So 3 points positive means 90% specificity for STEMI, ST elevation MI, and sensitivity of 36%. So these criteria they will help us to be slightly more accurate, and it is in the end your individual diagnosis, and the patient's life lies in your hands, and you have to know your stuff and diagnose and do the best you can for your patient. And yeah, so these we have done. This is a Valencyne biphasic T high LAD block. Okay, and so this we have done already. I don't know why it has come again. So pneumothorax, emphysema, cor pulmonale, LAHB can also cause small Q waves in anterior chest lead. So you should remember there is a deep S in lead 2, lead 3 LAD, and the Q waves have appeared which are not before. But still again you think of MI, think of the worst diagnosis, rule it out. No problem, no shame. You can be wrong in a diagnosis, keep the diagnosis of MI first, and if it is just pure LAHB causing Q waves, fine, no problems. Let people laugh, but you have saved a life. Acute pericarditis can cause concavity upwards ST elevation. So you have, this is something important, because in acute pericarditis, if you thrombolize this patient, okay, and you can cause hemopericardium, the condition will worsen, and after that you will be giving enoxaparin and things like clopidogrel and ecosprin, and that can create havoc. The patient can go into shock. So you have to be very careful when you diagnose MI, okay, with the concavity upwards. So concavity upwards means ST elevation with this type of ST concavity, not like this, like this. Then hyperkalemia can cause hyperacute T waves, which can simulate a hyperacute phase of MI. So thank you guys, we have finished our MIs and conduction blocks, and after 1 or 2 days we'll discuss the arrhythmias, okay, and then you'll be masters in your ECGs. Thank you so much, thank you for joining, and please leave your comments and like the video, and also tell your friends to watch these videos, and you share these links with your other colleagues and in your groups, social media groups and WhatsApp and Facebook groups, and so that this channel also gets some benefit. Thank you so much. Good night. Bye bye. God bless. Bye.